Dr. Hussein Bagha is a consultant physician and nephrologist working at the MP Shah Hospital in Nairobi. He is the head of the renal and transplant unit. He is also a member of the Royal College of Physicians of the United Kingdom. He's a fellow of the College of Physicians, ECSA, and also a fellow of the International Society of Nephrology. He has also completed his MRCP in nephrology. Dr. Bagha did his nephrology training at the University of Witwatersrand in South Africa. He has special interest in kidney transplantation and peritoneal dialysis. So please welcome Dr. Bagha for his presentation on hemoadsorption. Thank you.
Thank you very much, Dr. Musumbi, for those kind introductory remarks. I'm sure a lot of guys will be tired to hear my voice. This is going to be my fifth presentation. I hope you can see my slides.
Yes, we can see it quite well. Thank you.
Okay. So I'll be talking about hemoadsorption, and specifically in the era of COVID-19, the current pandemic that we are in right now. So just as by the way of the introduction, the coronavirus or the COVID-19 is an infectious disease which is caused by the newly discovered coronavirus, the SARS-CoV-2. And this is a beta coronavirus, which is in the same subgenus as a severe acute respiratory distress syndrome virus. And the first case reports of a novel coronavirus causing pneumonia was reported in December 2019 in Wuhan, China, which is a city in the Hubei province of China. It rapidly spread in China and subsequently became an epidemic, followed by a global pandemic. And worldwide, we have over 38 million cases of COVID-19 that have been reported. So the cartoon here is basically showing the structure of the COVID-19. We have the spike protein, which is found on the cell membrane, which consists of a lipid bilayer. And we also have the membrane glycoprotein and the nuclear capsid protein. So the presentation basically is quite non-specific. Most commonly, the patients present with fever, followed by a cough, and then they can also sometimes present with anorexia. Now we are also finding patients who come in with diarrhea and anosmia as well. So as you can see that the symptoms are quite non-specific, and unfortunately, by the time the patients present to us, most of the time it's a bit late. Thankfully, if you look at the illness severity, majority of the patients basically have mild to moderate symptoms, up to 81% of the patients. Only 14% have severe symptoms, which is classified as dyspnea or hypoxia, or more than 50% of the lung involvement on imaging. Very few patients, 5% actually present with critical illness, which is defined as respiratory failure, shock, or multi-organ system dysfunction. And the risk factors for the severe illness from this study in China show that it was basically age more than 80 years. And those patients with reported underlying medical conditions like cardiovascular disease, those patients who had diabetes or chronic respiratory disease, and even those who basically are on immunosuppressive therapies, like those patients who have undergone transplant. The diagnosis of COVID-19 requires the detection of the SARS-CoV-2 RNA by reverse transcription polymerase chain reaction, or the RT-PCR. And we normally use the nasal swab. But if you can't take the nasal swab for whatever reason, we can use an oropharyngeal swab, although the sensitivity is slightly less. Now, this is the most current data, which is showing the daily confirmed new cases in the 10 most affected countries. And you can see that in the green, we have the United States. It's basically showing that the number of cases are currently increasing. India had reached its peak in September, where they were recording more than 80,000 cases per day. Brazil was also very high, but now at least the numbers have started going down a bit. In the rest of the European countries, they're also experiencing the second surge, as you can see. If you look at the mortality, Mexico is the highest case fatality ratio of up to 9.9%, followed by Italy. But thankfully, in most of the countries, the case fatality rates are less than 5%. Now, if you look at the stages of infection and the natural course of the disease, we have divided the stages of infection into 3 stages: there's stage 1, stage 2, and stage 3. And if you look in stage 1, there's a very aggressive viral response in stage 1, whereby the the virus is basically replicating, and you have the highest number of the virus in stage 1. And unfortunately, at this point in time, we don't have a host inflammatory response. So basically, the virus is allowed to replicate, and subsequently, the patient becomes infective, and yet the patient is asymptomatic or is not picked up. So in this stage 1, we basically have very mild constitutional symptoms. The patient may or may not develop a fever, may have a dry cough, diarrhea, a bit of malaise, headaches. So a lot of time these symptoms are played down by the patients. And if you look at the lab parameters, they tend to get a lymphopenia at that point in time, an increased prothrombin time, an increased D-dimer and LDH, which is quite mild. Now, if it proceeds on to stage 2, which is called the pulmonary phase, this is a point at which now we start getting the host inflammatory response setting in as well. By this time now, the patients basically present with shortness of breath and hypoxia. And when you do their imaging, they have abnormal chest imaging. The laboratory parameters will show an element of transaminitis, and even the procalcitonin will still be normal at this point in time. If this goes unchecked, the patient goes into stage 3, then they go into the hyperinflammation phase, or what is called the cytokine storm. And at this point in time, the patients develop severe ARDS, they go into shock or septic shock and cardiac failure. The lab parameters get highly elevated inflammatory markers like the CRP, LDH, interleukin-6, D-dimers, and ferritins. They can also get troponin leaks or because of myocarditis and elevated pro-BNPs. There are the potential therapies which you can use at most of these stages. New antivirals, antimalarials. Unfortunately, most of these have not been shown to have any mortality benefits per se in these patients. Now, if you look at the pathogenesis, the SARS-CoV-2 virus actually enters the host cell within the lungs using the ACE2 receptor, using the spike protein which is found on the cell membrane. Once when it enters the cell, it translocates into the nucleus and uses the host's transcription mechanisms and factors to basically replicate to form new viruses, which now subsequently go on to infect the new cells. In this process, they also tend to activate interferon gamma, and which stimulates the release of interferons as well, other interferons. The virus, once when it enters a cell, it activates the polymorphonuclear leukocytes and the macrophages. The macrophages present the virus to the T cells because the macrophages are the antigen-presenting cells. Once when the T cells get activated, and if this is within the lung, they can activate the alveolar cells type 1 and alveolar cells type 2. And this basically leads to production of these cytokines. The T cells can also lead to production of cytokines like interleukin-6, tumor necrosis factor alpha, GCSF and GM-CSF. And all of this leads to a cytokine storm, which if left unchecked, can lead to necrosis, tissue damage, tissue destruction, influx of leukocytes, and dilatation of blood vessels. So even though the infection is within the lungs, it can lead to multi-organ dysfunction because of the cytokine storm. Now, this is a normal blood vessel, the way how it looks like in the microcirculation. You have your neutrophil, you have an intact glycocalyx, whereby it basically preserves the integrity of the endothelium, and your blood cells can actually pass through it. When you get the cytokine storm and damage to the endothelium, there's glycocalyx shedding, there's increased fluid extravasation, there's endothelial swelling, and subsequent release of the tissue factor, which leads to increased activation of the coagulation system, which leads to laying down of fibrin and microthrombosis. And this is been postulated to be one of the factors that leads to increased mortality because of the fact that you get an hypercoagulable state in COVID-19. And one of the therapies that has been used is heparin or enoxaparin to try and reduce this hypercoagulable state. Now, interferons are very, very important when it comes to the COVID-19 or viral infections, because remember that once when the virus starts replicating, it basically also activates the interferon gamma gene, and this leads to increased release of interferon. The interferon actually binds to the other cells and leads to transcription and increased production of antiviral proteins, which basically block the viral replication and synthesis. So what the interferons do is that they basically signal to uninfected cells to block RNA synthesis and replication. They signal infected cells to induce apoptosis, and they also activate the immune cells as well. However, remember that if it goes on unchecked, the increased activation of the immune cells actually leads to what is called the cytokine storm. And this is what it looks like. There's increased activation of your interleukin-6, interleukin-1, interleukin-10, 13. And this is what has been postulated to cause increased mortality in patients with COVID-19. So several drugs have been looked at to see what can be used against the COVID-19. And the recovery trial was one of the large randomized controlled trials looking at the possible treatments for patients admitted to hospital with COVID-19. And they had more than 11,000 patients, and they randomized them to either, it was an open label trial, and they randomized them to either lopinavir, ritonavir, low-dose dexamethasone, hydroxychloroquine, azithromycin, tocilizumab, and convalescent plasma. And what they found was that it's only the low-dose dexamethasone, which reduces death by up to 1/3 in hospitalized patients who required oxygen therapy. So the other therapies really did not show any reduction in mortality. Now, there was another therapy that has been looked at in septic patients in critical care, and this is polymyxin B hemoperfusion. And this was a paper by Professor Ronco et al. And what they were describing basically was the fact that polymyxin B actually binds to the lipopolysaccharide, which is found on the gram-negative bacteria. And this binding is quite strong and actually helps to remove the lipopolysaccharide, which is an endotoxin. And this is you can use a hemoperfusion on any dialysis device, be it the one that we use for intermittent hemodialysis, or the one we can use for CRRT, or it can even be used in the ECMO machine as well to remove the cytokines. So these are the various studies that were looking at cytosoap therapy in patients with sepsis and septic shock. Unfortunately, there have been very few trials done to assess cytosoap therapy in septic shock and severe sepsis. You can even see the numbers are quite few. And in most of them, majority of them, from these 6 studies that we have, there are 7, 5 out of the 7 studies actually showed a significant benefit in terms of reducing your vasopressor requirement and reducing your inflammatory markers as well. So endotoxins are basically very, very important when it comes to propagation of the cytokine storm. They're produced from the damage-associated molecular proteins and the pathogen-associated molecular proteins in sepsis. So you remove these endotoxins using the cytosoap therapy as well, it actually helps to reduce the cytokine storm. So what's the rationale of blood purification on COVID-19 patients? So the possible mechanisms of the innate system on severity of disease has been summarized here. So during the initial infection, there's a delayed or suppressed type 1 interferon response. And this allows the virus to replicate, as I mentioned earlier. This virus replication subsequently triggers a hyperinflammatory condition and a cytokine storm when the immune system kicks in. There's an influx of activated neutrophils and inflammatory monocytes and macrophages. There's a severe serum neutrophilia and elevated pro-inflammatory cytokines, which is subsequently associated with the severity of the disease. Now, this was a paper from Wuhan, which was looking at the adult patients, and they were assessing the risk factors for severity and mortality. And what they found was that the serum cytokine levels of interleukin-2, interleukin-6, interleukin-10, and TNF-alpha were significantly higher in patients with severe disease than in those with non-severe disease. And all of this was statistically significant, as I've highlighted here. This was another study that basically also looked at the risk factors associated with ARDS and death in patients with coronary virus. And they found that, again, patients who had got a high level of interleukin-6 actually had a higher risk of ARDS and mortality. So if you look at it, in summary, if you get a viral infection, it basically most commonly leads to a pneumonia. And if it's unchecked, it leads to a hyperinflammatory response within the lungs. And it can lead to severe ARDS. And because of this, you actually now tend to start using ECMO, as was described by the earlier speaker, Professor Carla. And even the ECMO itself, or mechanical ventilation, actually leads to increased release of your inflammatory cytokines. And subsequently, this causes a milieu of a cytokine storm, leading to endothelial dysfunction, which is widespread, leading to multi-organ dysfunction and subsequent mortality. So this article actually looked at the different approaches which we can use for cytokine removal. One of them was a direct hemoperfusion using a neutral macroporous sorbent. The other way we can remove the cytokines is plasma adsorption on a resin after plasma separation from whole blood, which is a bit more tedious. We can also use chronic kidney replacement, continuous kidney replacement therapy with hollow fibers, or CRRT with hollow fibers with adsorptive properties, or high dose CRRT with a medium cutoff or a high cutoff membranes. Cytokine removal is mainly carried out using the macroporous sorbent, and the dose is basically for more than 2 hours on 3 consecutive days. So we need to have a minimum of 3 sessions of hemoperfusion for it to be of any benefit. This was a statement from the NICE Institute, and what they were talking about is the cytokine adsorption devices for treating respiratory failure in people with COVID-19. And what they said in summary was that the technologies described in this briefing are cytokine adsorption devices, the cytosorb that we talked about, and therefore reducing the blood levels of cytokines in people with COVID-19 and respiratory failure. And these innovative aspects, the innovative aspects are that the cytokine adsorption devices reduce harmful levels of cytokines in the blood. And the intended place in therapy would be in addition to critical care for people with COVID-19 and respiratory failure. So, but what they say is that this is mainly evidence from non-randomized comparative single-arm observational study and a series of case reports. So again, even though it is basically mainly case reports and non-randomized trials, but even the NICE guidelines have postulated that yes, these therapies would be useful in patients who have got severe COVID-19 disease and who are mechanically ventilated because of the pathogenesis of the cytokine storm. These are the various studies that have been done. The first one was basically looking at sepsis-induced acute lung injury, and the other one was basically looking at high-volume hemofiltration plus hemoperfusion. And all of this basically concluded that it was effective. They effectively remove cytokines, improving oxygenation and stabilize hemodynamic status, and reduce ICU stay and improve the 28-day mortality rate. So these are the operation modes of hemoperfusion. You can use it just directly using the HA330 cartridge, using the normal intermittent hemodialysis machine. It can be used with SLED or CRRT using the continuous veno-venous hemofiltration. The HA330 can also be connected to the ECMO machine as well, so that it can help in removal of the cytokines that are going to be normally that are generated during the ECMO therapy and mechanical ventilation. The potential mechanisms of kidney damage in COVID-19 is summarized here. Normally, it's still postulated to be the cytokine release. Remember that we can also get direct infection of the tubular cells within the kidney by the virus itself. And another mechanism basically is also rhabdomyolysis. So these are the 3 potential mechanisms. But the cytokine storm is considered to be the most important mechanism of acute kidney injury and is part of the multi-organ dysfunction. And what this is proposing is that by removing the cytokines, you can actually reduce the risks of getting or developing renal dysfunction in COVID-19 infections. So this was a paper that was basically published in the Journal of Global Antimicrobial Resistance. It was a case report from Iran, and they basically were looking at HA380 hemoadsorption therapy with CRRT in the treatment of a 54-year-old man in Iran who developed severe COVID-19 pneumonia. And this was basically at admission time. The patient presented with symptoms of a fever of 38 degrees and a hypoxemia with peripheral saturations of oxygen of 90%, had a high CRP and a lymphopenia with severe respiratory acidosis. This was his initial chest X-ray. At that point in time, people were using hydroxychloroquine and lopinavir, ritonavir. This was initially, but this has been stopped. However, the patients actually progressed, went into severe ARDS, had to be mechanically ventilated. At this point in time, they started hemoperfusion, and you can see that there was a significant improvement in this patient. Cytosorb has also been authorized by FDA for emergency treatment of COVID-19, and is mainly for the severe COVID-19. And again, it's the same methodology that we can use. We can use it basically with your normal intermittent hemodialysis or CRRT or the ECMO machines. And what they say is that it has to be used judiciously because we still don't have concrete evidence per se that it works. Although if you look at the pathogenesis, it should help the patients. This was a laboratory study which was looking at the effects of hemoadsorption on cytokine removal and short-term survival in septic rats. This was a randomized control laboratory experiment where the rats were subjected to cecal ligation and puncture, and 20 hours later were randomized to receive either hemoadsorption or sham treatment using an AV circuit. And what they were looking at was basically the cytokine measurements and mean arterial pressures. What they found was that the hemoadsorption reduced the circulatory cytokines significantly and improved mean arterial pressures and resulted in better short-term survival in those rats who had sepsis induced by the cecal ligation and punctures. This was an ICU study looking at hemoadsorption with cytosorb. And what they showed was that what they demonstrated was that there was a decreased observed versus expected 28-day all-cause mortality in ICU patients with septic shock. This was a propensity score-weighted retrospective study. They had 210 patients, and 101 of the patients were in the cytosorb arm, 109 patients were in the CRRT arm, and they were analyzed for 28-day mortality. And what they found was that the patients who were in the cytosorb arm, the predicted mortality using the SOFA score was 74.5%, but the actual observed mortality was significantly less. It was even much less than the ones in the CRRT arm, as is shown here. So this was basically all the studies that have been done using the cytosorb therapy. I work at the MP Shah Hospital, and I've used quite a bit of the HA330 for hemoperfusion in the severe COVID infections. And this is the MP Shah experience. This is a hospital where I work at. It's a private level 5 hospital. This is the reception within, and this is the casualty. This is my dialysis unit. It's a 12-bedded dialysis unit. So MP Shah Hospital is a modern 210-bedded facility which is located within Nairobi. It has its own separate pediatric wing with its own pediatric casualty and pediatric intensive care unit. Has a 7-bedded adult ICU and a 9-bedded adult high dependency unit, fully equipped with a radiology unit with a 3 Tesla MRI and a 128 slice CT scan. It has an ultra-modern laboratory with a dedicated team of pathologists, and we also have a new tower for physiotherapy, maternity, specialty clinics, and transplant ward. Fortunately, it was ready, and we just converted it to the COVID ward when the pandemic started. So the first COVID-19 case was confirmed in Kenya on 12th of March 2020. As per today, we have 53,797 positive cases in Kenya, with a mortality of 981 cases. The total number of COVID-19 cases, this was basically over 6 months from March to end of August. We had 157 cases, out of which 26% actually required ICU care. 27 out of the patients who required ICU care, were males, which is 65.8%, and 14 were females. 10 of these patients who required ICU care actually succumbed to the disease, giving a mortality of 24%. Now, if you look at the mortality internationally for those critically ill patients who actually ended up in the intensive care unit because of severe or critical COVID-19, their mortality was more than 40%. So ours is 24%. So these are the various comorbidities of the patients who are admitted to the intensive care unit. Majority of the patients were hypertensive and diabetic. 2 of the patients had chronic kidney disease, 2 had chronic obstructive airway disease, 2 were asthmatic, 2 had a malignancy, and 1 was retroviral disease positive. So 14 out of the 41 patients, that's 34% of the patients, received hemoperfusion. So remember that in our setup, we have a lot of financial constraints as well. Even though it's a private hospital, the cost of the hemoperfusion per day is almost 60,000 shillings. So there's a lot of cost constraints. And this is the reason why only 34.1% of the patients receive the hemoperfusion, because you have to get consent from the relatives. 12 of these patients who received hemoperfusion were males, and 2 were female. The mean age was 52.9 years, and the median age was 52. Again, if you look at the comorbidities of these patients who received hemoperfusion, majority of them were diabetic and hypertensive. If you look at the outcomes, 4 out of the 10 patients succumbed. So we had 10 out of the 14 patients survived and actually went home. Out of those 4 who succumbed, 1 patient had COPD. He was a transferal from another facility where he had stayed there for 10 days. So basically, he came in quite late to us and he was intubated. And from the studies, it actually shows that you're supposed to start the hemoperfusion quite early. The families of the other 2 patients who died delayed in giving consent for the hemoperfusion. Again, there was a delay in starting the hemoperfusion, so we suspect that was also another reason why they succumbed to the disease. 1 patient was actually doing better and was about to be extubated, but had a sudden cardiac death following a rise in troponins and an arrhythmia. So we suspect that the patient had developed COVID-19 myocarditis, and this was the cause of death. So if you look at the conclusion, in summary, COVID-19 is more infectious than influenza, but has a lower overall mortality. As I said, it was only Mexico that had a mortality of almost 10%, but otherwise the mortality is less than 5%. Patients with the comorbidities, especially diabetes and hypertension or cardiovascular disease, have a higher mortality and morbidity. The mortality is mainly postulated to be due to the cytokine storm. The main treatment that has been shown to reduce mortality is dexamethasone. I know there was a paper that was published and the FDA has given approval for the use of remdesivir, but remdesivir just reduced the progression to severe disease. It has got no effects per se on mortality. Hemoperfusion is a promising modality of treatment for severe disease based on the pathogenesis and the cytokine storm. We have data that shows that there are positive outcomes for hemoperfusion, albeit a low number of patients that we have had, and more larger studies are needed to actually assess the hemoperfusion therapy for these septic patients with COVID-19. Thank you very much, and I'll end there. Over to you, Dr. Musumbi and Dr. Kabinga.
So actually, there's a question that just came through here from Thomas. What's your success with intubated COVID patients?
So basically, the patients that I used the hemoperfusion for were all COVID patients. Were all intubated COVID patients. So we use it mainly with the patients who have got severe ARDS, where your PO2 FiO2 ratio is less than 100, and all of them are on the ventilator. And 10 out of the 14 patients we used it on, we actually got them out of the vent and out of ICU and actually went home.
Okay, no, my question was whether this is being used in a research basis.
Yeah, there are several trials that are being carried out currently to assess, because
Yes.
this therapy has been used for patients with septic shock in critical care units from before. So then this was extrapolated to be used in COVID-19 because of the cytokine storm. So remember that we are very much limited in terms of the therapies that we have for severe COVID-19 disease. So this is the reason why we actually decided to go ahead and use it, because I've used this therapy in septic shock patients with good outcomes at the MP Shah Hospital. So when when we got this pandemic of COVID-19 and we decided to get patients being admitted to the intensive care unit, our options were quite limited, because what we were seeing was that there was an increased mortality once when the patient gets to the intensive care unit. And apart from dexamethasone, there's not much that you can do. We just have to support them. So this is when we decided to use the therapies. And of course, it was an informed consent after talking to the relatives that yes, this therapy there's no therapy that has been tried in COVID-19. So there are large RCTs that are currently going on looking at the hemoperfusion, and I'm sure they'll be published once when the trials are finished.